The third thing he was highlighting was puncturing of the septum from different approaches.
Number of people, both children and adults, experience medical.
Good, thank you. So I think we have got connected
Yes,
to
we have
Madras
started
Medical
coming.
Mission,
Yeah.
the live case.
And walk out with a new lease on life. The Madras Medical Mission Hospital, since 1987, has been synonymous with excellence in patient care and quality medical treatment at an affordable cost. And it continues to draw a large number of patients from various stratas of the society. The Institute of Cardiovascular Diseases, ICVD, at Triple M, has many firsts to its credit, including the first adult and pediatric heart transplantation in the private sector, percutaneous pulmonary valve implantation, first bilateral lung transplantation, first Ross procedures, first Batista procedure, and so on. The Institute is made up of several departments, including departments for adult and pediatric cardiology and surgery, and a department for cardiac rehabilitation. It is also home to some of the finest cardiac specialists in India. The catheterization lab at the Cardiovascular Diseases Department is a state-of-the-art facility that brings in a multidisciplinary team of doctors. It is here that diagnostic angiographic procedures and therapeutic interventional procedures are performed. With every surgery performed, with every patient treated, the Cardiovascular Diseases Department at Triple M reinforces its commitment to its missionary values. Every patient that comes in for treatment at the department, from a day-old baby to a 90-year-old, is an opportunity to further the Madras Medical Mission's goal of reaching out to the unreached.
Yeah, hi.
Good morning.
Good morning. So, Dr. Ajit, it's Dr. Viveka and Dr. William Vines, and we have uh, Dr. Brijesh Mittal on the
Well,
panel.
let's go quickly.
Yep. Please introduce your case.
Well, thank you very much. Sorry for that little delay. There were some connection problems. But I'm just going to quickly go through the case history. So this is a very interesting case. So can you show us the case history, please, at the auditorium? So this is this 68-year-old male, anteroseptal MI, not lysed. And the angiogram we will show you soon has double vessel disease with mild LV dysfunction. The renal parameters are okay. And you can see the syntax score downstairs, a total syntax of about 9. So this is the previous angiogram done. And that shows that in this view there is a borderline LAD lesion at the ostium, and you can see the next view, you can see that there is an ostium LAD lesion which extends into the left main. The right has got multiple lesions in the mid-segment and in the distal RCA. So our plan today is to, one, assess the LAD lesion, whether it is right at the ostium and is it extending into the left main. We also want to know what would be the strategy to fix the LAD ostium, whether it will be a stent right at the ostium or will it extend into the left main, and we will use imaging to see what is the status of those lesions.
Yeah, so what kind of
And
imaging?
following which we will assess the functional status of the RCA and with an FFR, and then plan to do the right. So I would like the comments from the panel and the chairpersons, and we will be using OCT to evaluate the LAD and the left main.
Thank you. Very clear plan. Just one question. What was the delay from the MI and the lytic therapy?
Well, the patient did not receive lytics, and this is a common problem in India. At least in our studies in Tamil Nadu, about 15% don't get lysed or get primary PCI during an acute MI, and many of them will present like this with possible spontaneous lysis.
Thank you. So can we ask the panelists to address your question?
What was the ejection fraction?
Oh, ejection fraction is the question.
It was about 40%.
Stent ready வச்சுக்கலாம்.
Although the imaging is important here, but will it make any difference in your strategy whether it extends into left main or not?
Well, I think it would, because number one, we will know whether the left main ostium is diseased at all or not. Number two, I see some craggy lesion in the proximal LAD also, so I would know exactly what length of the stent to be used, whether it should cover right up to the diagonal, or should we restrict it, or should it be a focal stent?
So you can proceed the imaging and just show us what did you find in the imaging.
Yeah, so we've done an imaging just because there was some delay in the transmission, and I will show you the imaging pictures.
Angiograms first cut, இன்னைக்கு angiogram.
So can we get the imaging on live on the screen, please? Okay, so my colleague Dr. Vijay Kumar will speak on the OCT.
Good morning. We started our imaging a little beyond a diagonal branch. Can you see the pullback? So beyond diagonal branch, about 5 to 6 millimeter normal vessel lies. And if you see backwards, this is mostly a fibrous block, the whole vessel is diseased. And if you just see this again fibrous block at 11 to 12, some calcium at 12 o'clock position now. And now we are close to the big septal here. Again, you can see a big calcium here. And this coming close to the LAD ostium, tight stenosis here. Stop here, stop. So if you see from 3 to 6 o'clock position, you can see an organized thrombus. Keep playing. And it is all fibroathyroma with the calcium on one side. Stop here. You can see here at 12 to 1 o'clock position, you can see calcium. Other areas all thick cap fibroathyroma with a fibrous cap thickness of 100 micrometers. Keep playing. And the disease extends all the way to the ostium and distal left main. Just see here. Yeah, we are into distal left main now. And we had some measurements. Distal left main is 4.1 millimeter. The landing zone distally is 2.75 millimeter. And the length is about 35 millimeters.
Thank you. Can you show us the circumflex
and there was
origin?
an issue whether to use just show the sarcostium. Yeah, here. It is all obliquity artifact here, the catheter is eccentric on one side, and just show the long view. Long view, yeah. Yeah, you can see the circumflex arms. No, just, yeah. Stop it, yeah. At the 35 millimeters is a circumflex ostium. Any comments?
Yeah, just show us again the distal left main so we can appreciate the disease there.
This left main is wide open, but disease is extending up to the ostium of the LAD. Just see some fibrous plaque, and otherwise the lumen is very big. So what do you think, whether we have to start from the ostial LAD or into the distal left main?
Can we ask our panelists whether you try to stop the stent right at the ostium or will you go into the distal left main based on the imaging?
Well, since you demonstrated that disease extends to left main distal, it has to be from left main.
Yeah, so Ajit, what would be your strategy
That's our
now?
plan here.
So can you explain?
To put a stent, but we first need to prepare the bed.
Can you tell?
And we felt that it was a fibrotic lesion in the LAD ostium, so we need to use a angioscalp balloon to open up the ostium of the LAD and then proceed with the stenting. So we plan to use a 3-0 angioscalp to do. So here we have just put the angioscalp there and dilated there, and you can just see the post pictures. So what the plan now is to put a stent which is approximately 38 millimeters, which will cover from, you can put up there, the distal LAD to the proximal left main. So the length is approximately 38 millimeters. And the distal diameter, as you see, is a little bit underfilled on the OCT, though we gave nitroglycerin, the distal diameter was 275, but I think I will use a 3-0 for the distal and use a stent which will get me to about 4.25, 4.5 in the left wing.
So we have two stents, and you have integrity, which goes 3 millimeter, goes up to 4.5, 4.7 millimeter, and synergy, which goes up to 4.25 millimeter.
That sounds like a great plan.
On the strategy.
Yeah, I think it's a great strategy. You explained your sizing decision and the landing zone. One question is about the thrombus. You mentioned there was organized thrombus. Does that change your strategy in any way?
Well, I would be very careful. Well, my colleague told me that we need to be careful of the thrombus, and so I would be very wary of no reflow when we are putting the balloon or the stent, and I would be very ready to tackle any of that issues which come with that.
Excellent.
He's already on dual antiplatelet therapy and
So which antiplatelet you have used, Ajit?
other antithrombotic measures. He's on clopidogrel, Plavix, PD, and aspirin.
Okay.
Okay, so we will go ahead in the interest of time with the stent. So we've chosen this is a 38 millimeters synergy stent, and I've kept a wire in the circumflex just to protect it,
Distal landing zone,
and we will go ahead.
The stand in the, I think the size distal is 3.5. What did they measure at OCT?
On the OCT,
275, so we went up with the 0.25.
Yeah, that is based on.
And this stent is no problem at all, whatever diameter you want, up to 4.25 you can post dilate it.
I think the issue of the sizing distally is increasing now as, for instance, in a trial like Illumin 4, it will be recommended to size on the elastic external lamina rather than on the lumen. This may change our practice in the future, I think.
We have just gone up by 0.25.
yeah, I take your point that we need to use the external elastic lumina. So just taking a couple of perpendicular pictures just to be sure. So we were going to do, if you looked at that, your OCT, you would see that there was some disease in the proximal proximal left main. So I'm just going to use a stent which will cover right from the mouth of the left main to the LA. So we are okay distally, and I think we are okay osteotic spontaneity. Okay, just go to the one more area failure. Okay, small check. Okay, so let's take the sitting. Okay, just take an RA caudal, please.
Can we see the cine again? We're having the catheters here.
Just a minute, I will play back those the cine. So can we have the cine on the angio pictures and not the OCT? Okay, so this is the RAO caudal. And can you show them the RAO cranium? Do you think that is sort of adequate? Small check, please. Small check, please. Yes, sir. I think that should be okay. We go up there. Yeah.
What is the normal? We go up to 11.
So we're going up with the trio synergy at the normal rates.
11.
That's about 11 atmospheres, and
Keep it short.
we will deflate these.
Stage 4 is
So we noticed you're very careful in manipulation of the guiding to make sure it doesn't hit the proximal part of the stent that is presently, of course, under-deployed in the left main.
Yeah, so I think what we need to be is very careful that we don't hit the stent. And also that we don't, pull the guiding right out.
Yeah, absolutely, because if you would lose wire position, it will be extremely difficult to recross, well, at this moment when the stent in the left main is not fully deployed yet.
What probably he was doing was he was pulling wire along with the balloon. That decreases the resistance. So that possibly didn't get guide dip into the left main.
Okay, so I'm okay overall, but I have not got a very great picture, but I'm okay. So
Yeah.
I'm just going to now finish the validation of the distal stand and the proximal stand, and then take some nice pictures. So 3-0 non-compliant overlap. And as I do this, I would like to go to the other lab, if you are okay, so we can show the case from the other lab.
Sure.
We can. Yeah, Ajit, you are live
Give
with
me
us
the-
now. So can you tell what did you do
Can you
when
come
we were in the
quickly,
other
sir?
lab?
We don't have only 10 minutes.
Yeah.
We have to do a part. Come, let's rewire.
Where we had deployed the Synergy, as you know, the 3O stent at 38 millimeter length, and then we did a post-dilatation
Connect.
with a 3O balloon.
One issue.
Can you go post-dilatation, please?
Connected.
Okay, so that's a 3O balloon, non-compliant at 20 atmospheres distal, right through the LAD, and then the next shot, we put a 4O for the
Eight.
left main and just at the ostium of the LAD. And what I want to show you is I'm all the time keeping the guiding out because you don't need to be very careful with the ostium struts. And I'll show you the next picture, which looks reasonable. Again, my guiding is right out. Next shot, please.
Do you keep the wire on the side branch or I see it is removed, so while doing part. What's the right
Yeah,
strategy?
I removed it because two reasons. Yeah, it's just because the circumflex is widely open, and sometimes because of the wire entanglement, you may have troubles getting the balloons down. So I normally, once I see the circosteum open, then I just pull off the wire so that I don't need any marker for where to get through. And I'd like you to now show you some nice pictures of the
Change to
OCT. Can you have the OCT? So this
Yeah.
is the pullback OCT.
Okay. If you see here, our distal landing zone is good. We have an area of more than 4.5, and there is no dissection, no hematoma, and stent is well expanded and opposed. And in the LAD part, we had a minimal human area of 5.3 millimeter square. It is at the distal edge. Ostium is about 6.9 millimeter square, and the left main area is 13.6. If you carefully see the MSO, metallic stent optimization, the LAD part of the stent is well opposed. It is almost white. And if you see the bifurcation, LCX, you can just see side branch related malapposition that is shown as red color. Can you see here?
Yeah,
Just see close to 40. Yeah, you can see a red indicator. So that is all side branch related malapposition. We are not going to address it. And if you come proximally, you can see something interesting. Keep coming. And we just little deformed the stent with the guiding catheter. You can just see a crowding of stent studs at the ostium at 50. And we went back and redilated that part at very high pressures. And this is the final picture.
Beautiful. I think with such a long stent, opportunities for under expansion or under deployment are many, and that's where the OCT
Very
is
high, yeah.
helpful. Can you also show us the distal edge, because that's perhaps one other point of interest, making sure at the landing zone distally that there is no edge dissection? These are beautiful images, wonderful.
There is no edge dissection. There was little plaque, but distal edge. Go, show the cross. Yeah, there is no edge dissection. There's a little fibrous plaque from 4 o'clock to 6 o'clock, but lumen areas are good.
So you beautifully illustrate here the amount of tapering that you can obtain by using, increasing balloon sizes as you go from distal to proximal for post-dilatation. Wonderful.
Yep. So
Just show the RA pictures.
So we can show you the last two pictures, and I don't know how much time we have, but we're now trying to address the RCA for its FFR. So if we have a minute, I'll try to get the wire down. So we have the right in. Can we show the right coronary artery diagnostic angiography, guiding catheter angiography? So this is the right, and you can see that you have a mid-segment lesion which looks about 70 and a mild distal disease.
There are only 2 small branches. We expect this to be negative.
Okay, can I ask our panelists, would
so
you
let
care
me see
to
what the
guess
numbers-
what will the functional imaging measurement show here? Will it, you think FFR will be abnormal or preserved?
We have to equalize, sir. We have to equalize once you go.
Seems it could be abnormal, because
We have to go.
there are 2 lesions and both look good, you know.
Guiding is out.
So we have
Looks
16
significant.
minutes left, Ajit, you can take your own time.
Okay.
Okay.
Ajit, what do you think? You think it's going to be abnormal, or you expect a more preserved type of FFR?
I think the FFR in my field would be negative, but I'm not going to be 100% on that. And you can see that you need to be very coaxial with the guiding.
Yeah.
Small check, please. And these FFR wires are a little difficult to use sometimes. And can I get to the RAO? Yeah.
Yeah, on one side it is several diseases in series, and there is diffuse disease, so that would suggest that perhaps the FFR will be abnormal. On the other hand, the distal zone, I mean, the number of branches is relatively limited, so the amount of increase in the volume flow with the hyperemia will also be limited. So if there is no gradient at rest, I would guess that perhaps it will be preserved. More because the distal territory is not that big than, and because of the severity of the lesions by themselves. But no, we have to measure.
Okay, so you can see that the ostium of the right is a little unusual. So what I'm going to do is use a routine wire, get a routine coronary wire, and sort of get that wire in, and then use the FFR wire after I get the wire.
One more
Because the
increase.
FFR wire can sometimes go back to the LAO, please.
Yes, sir.
Yeah.
Go and come back.
I guess this is almost
So the
universal
FFR wire
experience.
is
Oh,
sometimes a little,
please go ahead.
Matthew, switch and come back.
yeah. So as I get the wire, I think Dr. Sengutwell wants to show quickly the pictures of his stent. So maybe you should quickly go to the other lab and come back by the time I get the.
Yeah.
Yeah, Ajit, you're live now, and we wanted to see what was the FFR finding.
Okay. Okay, so what we did was that the FFR wire is sometimes a little difficult to use. So what I did was I changed, other guiding was not really helping, so I just changed to an Amplats, and even with the Amplats, the FFR was not really good. The wire was not going through nicely. So what I did simply was that I got another wire, a floppy wire down to support the guiding,
Stop screening.
and then got the FFR wire in, and first step then is to equalize. And can you show the equalization? Can you show the picture of the wire outside the guide but before the lesion,
Equalization. Next. Keep going.
and show us the FFR?
So PDPA is,
Yeah.
we are sure that we have crossed the distal lesions. We have to go in a little bit more. Sir. Yes,
Yeah.
we have enough.
So can we go to the next picture, the next? So you can see that this is where, can you go next? Next, please.
We are not recorded.
Okay. Anyway, you can see that I had put the wire in the branch to support the guiding, but still the FFR wire would not move very well, and I'm very unhappy when the FFR wire doesn't move. So I changed it to the guiding, and what I've now done is equalize. Can you show the equalization on the screen?
We have to go a little bit
Go to the
more.
FFR equalization, please. Get the FFR, please.
Yes, sir. That we are done.
Can we have the FFR trace, please, on the screen? Yeah. So that's equalized, and now we have across both the lesions in the right.
Right.
And you can see, can you make that the bigger picture and the angio as the smaller picture? So Vijay, can we sort of read the PDPA and the
Yeah, we keep having the proximal pressure a bit lower, a few millimeters mercury than the distal one.
yes.
Maybe closing the
just checking
TUI
that.
or...
Yeah, but I think, yeah.
Yeah, we're just checking that. We have removed two EBOs, this introducer, and maybe a little dripped, I think.
Maybe a little drift, I think,
No,
but
it's stable. I mean, from the beginning, we've seen 1 or 2 extra millimeters mercury. Are you planning
And there's
to...
absolutely no gradient.
At rest, you mean?
Yeah, we are going to give an adenosine anyway.
Yeah,
It will appear
yeah.
definitely be negative. It's not
Yeah.
adenosine, sister.
Yeah, are you going to, for
So
IC or
we're
IV?
going through
What-
with
So will you give adenosine intracardiac?
IV. We always use
IV,
IV.
yeah, yeah.
IVs.
So with the
We always
amplats
use IV
being...
because we've also got IFR in our labs
Start.
Yeah.
and
Ah,
FFR pullback, so we find IV adenosine convenient. Yeah.
Sure. But even so,
Not
I,
adenosine.
I would recommend that you disengage the guide at some point in time while the IV is running
Okay.
to make sure the presence of the guide in the ostium,
Yeah.
particularly the amplats, doesn't impede maximal increase in flow.
Little. Once we get the maximum hyperemia, we do it.
Yes.
The guiding is a bit unstable sitting there, so
But
We
it's,
have just
it,
1 more minute to go.
yeah, it's very unlikely to be abnormal though.
Yeah.
With no
So
pressure
we-
gradient at rest.
yeah. I think yeah.
The one
And it's a
situation...
very small territory, very
Yeah,
highly
small
unlikely.
territory. The one situation where you can see a huge mismatch between a preserved resting gradient and a very abnormal FFR is when you have huge distribution volume, lots of myocardium downstream, which is
Oh,
not the
yeah.
case here.
Yeah, we have already got this adenosine effect. It is 0.96 now, and hardly any gradient still.
Yeah,
And
I'm
we are
just-
pulling back the guiding a little bit now,
I'm just pulling back the guide.
and there's no change.
Yeah.
கொஞ்சம் மூச்சு தண்ணல இருக்குமா வரி பண்ணாத.
Super. Very
So
nice
we are pretty
demonstration.
out of the guiding now.
Can we see the angio? Just show us a fluoro.
And,
Where is your guide?
Okay. Yeah.
No, sir. Okay.
Mold check. Yeah, maybe a little bit more, and I'll do that.
Yeah, just
that
pushing the wire a
amp
bit.
Just jump. So
Yeah,
the
I think we are almost out.
Yes, excellent. Now you know for sure that there is no obstacle to
Okay, that's good, that's
maximal increase in flow, and therefore you're truly measuring FFR if the adenosine is running properly.
Yes, sir.
So I guess as you've
Yes.
anticipated,
yeah.
No.
preserved FFR, no need for
Not right.
Yeah.
extra intervention here.
Yeah, it is
Beautifully done.
0.9596, and
Great points. Thank you
So
very
I think,
much.
we have come
Fantastic.
to an end
Yeah.
of this session, and we must, give a big hand to Ajit for nice demonstration. Thank you, Ajit, for the great piece of work and showing
you.
us about FFR and OCT and how to tackle the osteal lesion. So thank you, panelists, and
Thank you.
every one of you be here.